So good afternoon, everyone. This is basically a session for postgraduates. As you know, neuroophthalmology is a tough one for the PG exam, but all the examiners ask their neuroophthalmology case is you have to keep a neuroophthalm case. So we basically aim for the postgraduates, but I think at the end of the session, the general ophthalmologist also get some useful information, and we have selected our topics in such a way that at the end of the session you can have so many tips. Okay, we straight away go to our session. First, as you know, the optic disc is the most important, essential, integral part. We start with the optic disc evaluation. Instead of Dr. Dhanya, Dr. Lima Rose Thomas, she is assistant professor from Government TD Medical College, Alappuzha. Over to Dr. Lima.
Good evening, everyone. First of all, let me thank KSOS as well as Dr. Maliga Madam to give me this opportunity. As you know, so optic disc is a small blind spot on the surface of the retina. It does not contain any photoreceptors, and the millions of fibers that originate from the ganglion cells travel to the brain through the optic nerve. Now, optic nerve head has three parts. One is a cup, which is a central depression, which is the size of the cup is genetically determined, and for a given number of nerve fibers, larger the disc, larger the cup. The disc margin is denoted by the scleral ring. The neuroretinal rim is a tissue between the cup and the disc margin. This tissue consists mainly of nerve fibers and some glial cells, and usually pink. A systematic approach for the examination of the optic disc and retinal fiber layer is essential. The standard method, obviously, we are all doing the slit lamp biomicroscopy with handheld lenses, which is the best method because it gives magnification as well as stereopsis. Now, we use contact lenses as well as non-contact lenses. A contact lens is the Goldman lens, 3-mirror lens, and the non-contact lens have the high minus, that's the ruby lens, as well as the high plus lens. Obviously, the most commonly used is a high plus lens. So we have 60D, 60-60, 70D, and 90D. It is easier to use, uses the power of the lens in combination with the cornea to give you an image between the condensing lens and the slit lamp, and it gives you a wider field of view. Now, lower diopter lens, more axial resolution and the better stereopsis. And 60D gives you a high magnification. It's good for size measurement. 70D gives a good balance between the field and the magnification. And 90D is the most commonly used. It gives wide field and a good resolution. Now, basically the procedure is you dilate the pupil, the patient is positioned comfortably, viewing and illumination is kept axial. The slit lamp, you keep it as a minimum intensity, about 2 millimeter wide and 5 millimeter height. Beam is focused on the patient's pupil. You see the condensing lens at the working distance. Red reflects from the fundus, slit lamp is pulled backwards. You see as it has a V, you see the dilated pupil, you see the slit beam adjusted to the pupil size, red glow is seen, the condensing lens is now placed in between this thing, and then you pull back the slit lamp, you see this, and then you adjust your slit, to make it very precise in this thing, and then you actually reduce the height to match the disc size so as to measure its vertical diameter. And then, of course, you also have to widen it and look for the peripapillary region as well as the RNFL around it. Okay, that's what you do. Then, in young patients, you can do an undilated examination also, but you should make sure that you're having the stereopsis by making sure that you're viewing with both the eyes. Now, what are the things that you look for? You look for the disc margin. You look for the rim, you look for the cup, you look for the vertical disc diameter, you also look for the vertical cup size, and you look for the disc vessels. Okay. Now, the size is a wide range one. You can have a small disc to the large disc, all of them normal, and the shape is usually vertically oval, but almost all the sizes that is shown here are normal. Now, look at the disc margin. So, you look whether it's well defined or it's blurred, as in papilledema. Now, disc size, you place a slit lamp coaxial with the observation, and using a vertical beam in a scale calibrated in meter, you measure the disc diameter, and you should also consider the magnification factors of the lenses. 66D is 1 and the closest to is 78D. Cup disc ratio, 0.1 CDR, 0.4, 0.7, 0.8. That is comparison of the vertical disc diameter to the cup cup diameter, and for a larger disc, even the larger disc, a larger cup is normal, but 0.3 to 0.5 is considered normal. Now, neuroretinal rim, you look at the ascent rule, that is the inferior rim is more than the superior rim, and then that is more than the nasal and the temporal, and whether the rule is broken. Then you also look for the outer border of the scleral ring. You look at the cup edge, you look for the bending of the vessels. That gives you an indication where the cup edge is. You also look for the circumlinear vessel. So there is findings like bearing of circumlinear vessel, which gives you an indication that the NRR is fallen backwards and the cup is the vessel is bare. You can also see diffuse rim loss or focal notches. Now, rim color is usually pink, and it can be pale or hyperemic. Pale denoting atrophy and hyperemic in disc edemas. Now, disc elevation, sometimes it is pseudodisc in a pseudoneuritic disc or a crowded disc. Or you also see sectoral edema in AON and papilledema. You can also measure the using a direct ophthalmoscope, where you focus initially on the vessels around the disc and then focus on the disc, and the difference in diopters is noted. And in papilledema, you get more than 6 diopters. And in optic neuritis, you get diopters of +2 to +6. Now, you look at the disc vessels, the findings is one is nasalization of vessels in normal disc. In normal disc, if it is large also, you can see the nasalization of vessels. But, and also bionetting, where the blood vessels seem to undercut the rim or scleral ring in a deepened cup. Now, disc and RNFL hemorrhages are very important. It's a strong predictor of the progression of, in case of glaucoma. It eventually resolved, leaving a rim thinning, a new RNFL defect, and a new visual field defect. So sometimes it can be very obvious and sometimes it is subtle. Therefore, it's very important that the glaucoma patients on follow-up also requires a disc examination. Then the other conditions with disc hemorrhages would be AON, hypertensive retinopathy, and vein occlusions. Now, retinal nerve fiber layer, you have striations. You can see the normal pattern on this side. And sometimes it can be diffuse RNFLs, where you see the vessels are a little bared. It's well seen in a red-free filter. And you can see focal loss, as in wedge NFLD, in the second picture, where there is a focal loss. Now, peripapillary atrophy is very important. You can see the alpha zone.